So Dr. Priyadharshini Palaniyappan. Please go on.
Good evening, everyone. My topic is disc edema, differentials and management case series report in a secondary eye care center. This is a case series report of 3 cases of different causes of disc edema. Case 1, a 70-year-old female presented with painful blurring of vision for the past 2 months. She is a known diabetic, hypertension and coronary heart disease patient. She was on irregular medication. Her BP was measured was 180, 120 millimeter of mercury. There was no history of any headache or fever. On examination, her BCV of right eye was 6.6 and 6, left eye was 6.12 and 8. The only color vision was reduced. Pupil reaction and extraocular movements was normal. Fundus image, both eyes, there was disc edema with splinter hemorrhages in both eyes. OCT showed disc edema in both eyes and macula was normal. MRI brain was done, which showed small vessel ischemic changes. A diagnosis of grade 4 hypertensive retinopathy was made. Neurologist's opinion was taken and the patient was started on systemic medications and anticoagulants. On follow-up, her both eyes vision improved to 6.6 and 6, color vision improved to 3/21. Fundus examination, there was resolving disc edema with temporal pallor. On follow-up, the both eye showed a inferior field defect. Case 2, a 51-year-old female presented with painless diminution of vision in both eyes. She is a known diabetic hypertensive patient on irregular treatment. On examination, BCA of both eye was 1/60 and 36. Her extraocular movements was normal. Pupil was sluggish reacting and color vision was reduced. The fundus image showed both eye there was disc edema with splinter hemorrhages and there was retinopathy changes in both eyes. OCT showed disc edema and retinal thickening with the hyperreflective foci more in the right eye. FFA was done. The right eye showed extensive disc leakage, NBD and NBE was seen, and both eyes there was extensive capillary non-perfusion areas. A diagnosis of both eye non-arthritic anti-ischemic optic neuropathy with proliferative diabetic retinopathy in right eye and severe non-proliferative diabetic retinopathy in left eye was made. She was started on systemic medications, insulin and oral medications, and laser was done in the right eye and anti-VEGF bevacizumab injection was given in the right eye. Her field defect in the last visit showed severely depressed fields. On follow-up, her vision improved to 5/60 and 36, and left eye improved to 6/24 and 24. There was pale disc in both eyes. Case 3, 36-year-old female presented with painful blurring of vision in left eye with headache for the past 2 months. There was no any systemic history or any fever. On examination, right eye was 6.6 and 6. Examination of the left eye, the vision was 6/12 and 9. Pupil reaction was normal. There was vit cells in the anterior vitreous face. The right eye fundus was normal. Left eye showed vit cells. There was disc edema with superficial hemorrhages and subretinal fluid was seen in the posterior pole. OCT of the right eye was normal. Left eye showed disc edema and subretinal fluid. Investigation, baseline uveitic workup was negative. Only IgM leptospira was positive. Her MRI brain was normal. A diagnosis of left eye leptospirosis neuroretinitis was made. She was treated with intravenous methylprednisolone, oral doxycycline, and tapering oral steroids. On 3-month follow-up, her vision improved to 6.6 and 6. Her eye was square. The fundus of the left eye, temporal pallor and RP changes was noted. The macula showed a resolved subretinal fluid. Discussion, all disc edema cases need careful evaluation of the history, whether they are taking the medications normally, and BP, RBS, and the MRI brain and orbit is advised. Medical therapy will depend on the underlying etiology. Non-granulomatous anti-uveitis or pan-uveitis is the most commonly reported form of leptospirosis uveitis. IgM ELISA will help in the diagnosis. Treatment with oral doxy and systemic steroids give favorable results. Conclusion, neurophthalmic cases with the relevant systemic and blood investigation workup with the physician approach will help in the preventing vision loss and further treatments. These are my references. Thank you.
Thank you. So, in that first case, you diagnosed it as grade 4 hypertensive retinopathy. What were the points in favor of diagnosis?
Her BP was high, ma'am, 180, 120, and there was disc edema and splinter hemorrhages, and
Like in that fundus photo which you showed us, only disc edema was visible. Huh? There were no soft exudates, no flame-shaped hemorrhages. You did a macular OCT and there was no edema also.
no.
So how did you come to that diagnosis?
She came to me in the first week itself. There was not many on the follow-up also. On starting the regular medications, within 2 weeks the disc edema resolved, and MRI brain was normal for her because she was 77 years and there was no headache. So this was a possible diagnosis.
Did you do other blood investigations?
Yes, I did a CBC, ESR and everything, and her sugar was under control. Only her BP was high, and fasting lipid profile was high, so that she was started on lipid tablets also.
So she had an inferior field defect.
Yes.
How do you explain that?
The small ischemic vessel changes, MRI, maybe that explains.
Check.